I'm going to introduce Dr. Neill Epperson. She is a renowned psychiatrist, professor, and prolific researcher. She is internationally known for her unique lifespan approach to mood and cognitive health during reproductive transitions like pregnancy, postpartum, and menopause. She is a professor and chair of the Department of Psychiatry at the University of Colorado's Anschutz Medical Campus. She is also the executive director of the Depression Center and a professor in the Department of Family Medicine. Prior to this, she served as founder and director of the University of Pennsylvania Center for Women's Behavioral Wellness. So let's get started. Welcome, Dr. Epperson.
Well, thank you, Donna. I just want to say it's such a treat to be with you today. I am so grateful to your organization, Let's Talk Menopause. It really is so important for people to really feel comfortable talking about what happens as we age and go through this transition. And so in any case, it's just really delightful, and I'm so looking forward to working with you today.
That's great. Thank you. And so let's just talk about definitions first. What does cognitive functioning mean?
Great. And I'm going to spend just a little bit of time. I know we want this to be a conversation, but this is so important that people are grounded in what we mean by cognition, because I can tell you, even a lot of my colleagues in psychiatry and neuroscience, if you don't study cognition, if you don't treat cognitive issues, you have a tendency to kind of refer to everything as memory. My memory is not good. And the first thing I do when a patient comes to me, or a friend, or I'm at a cocktail party and people say, oh yeah, my memory is terrible. I want to understand what they mean by that. And cognition encompasses many things that can come across like this concept of memory, because we experience it like that. For example, you're at a cocktail party and you see your boss and their spouse coming towards you, and you're going, I know I have met my boss's spouse like 10 times and I cannot remember that person's name. And then all of a sudden you get this surge of anxiety and you're like thinking to yourself, oh my gosh, what's wrong with me that I can't remember this person's name? It's going to be so embarrassing. Or you go into another room and you can't remember why you went in there, or you lay down your keys. And so people say, oh, I have terrible memory problems. I can't think of the word, or what have you. And again, these are examples of not being able to remember something, but it's very complicated why you might not be able to remember it. And you shouldn't all of a sudden assume that you're having dementia because you can't remember these things. These particular aspects of memory are really embedded in parts of the brain that are sort of more primitive, they cut across different mammalian species. And many of your listeners might have heard the term the hippocampus. It sits like, if you were to put your finger right here and go deep into your brain, you would probably hit part of the hippocampus. And that part of the brain really is there to help us kind of remember, from a more primitive time when things were dangerous, when we needed to run away from something, or when we needed to encode memories that were important for survival. I'm not sure that your boss's wife and remembering the name is a matter of survival. Okay. So the other part of the brain that is also really important is this part that is more sort of peripheral, sort of close to the scalp. Which is called the prefrontal cortex. And that is a much more, quote unquote, modern part of the brain. It's what distinguishes us from other species. And it's responsible for aspects of cognition that are important for our day-to-day life. Again, remembering your boss's spouse name is not important for your day-to-day life. It's about this part of the brain is where we decide what's important. We decide this is worth remembering, or we need to pay attention when we're at a party and we want to encode somebody's name so that we know it later. You certainly should know your boss's name. You want to encode that, so you need to pay attention. So that part of the brain is really important for things like, how do we feel? Or how do we think about how we feel? How do we know that something's important to remember? How do we organize ourselves? How do we get up in the morning and know what to do next and get up and do it? And we can take in information and strategize about it. It's that executive part of our brain that makes us uniquely human. So cognition encompasses all of these things. It's not just about, oh, can I remember a word? And so I think it's really important that we have that foundation, because the brain regions are different, and it's different aspects of these types of cognition can be impacted in normal aging versus things like dementia. So with that basis, let's go from there. Hopefully.
No, that's actually very, very helpful. So the last part you were talking about was executive functioning, right?
Yes.
So sort of like there's memory and remembering words, and then executive functioning, which is sort of like preparing, thinking about things in a bigger way. Like
Exactly. Organized, knowing that to get to D, I need to go through A, B, and C. And if somebody walks in my door and interrupts me between A and B, I don't have to start back over at A. I know I can go to C and D. And those aspects help us to multitask, help us to be organized and maintain, moving forward in a goal-directed fashion. The hippocampus, again, is really important for learning and memory. So like when you're studying for a test and you want to encode data, that data, the more you practice it, the better the data gets encoded. If you're used to making a certain recipe, like I make Southern biscuits, I'm from the South. And so my biscuits are like legendary. I'm telling you, the Denver Biscuit Company ain't got nothing.
Your other profession, if you need it.
Oh, but if all of a sudden I completely forgot how to make biscuits because I've done this so long, that would be something to be concerned about versus, did I just forget if it was a half teaspoon of something? I still know how to make the biscuits. I may have to remind myself of a piece of it, but that information has been encoded because of having done it so often.
Got it. And we'll get to more of that, sort of the difference to our audience, the difference between like when you really should be worried. But let's now sort of go back a little bit, and let's just talk about what happens to women when they age and they start going through perimenopause. What happens to their cognitive functioning?
Okay. Basically, aging impacts everybody. It's not just a female thing, so I want to make that very clear. And aging also impacts every human being, whether you identify as male or female or not, or your gender identity is inconsistent with the way you were sexed at birth. So being a human being, regardless, we know that as we all age, that we're going to have cognitive changes. And if you think about it, it takes a long time for evolution to happen. And, back in 1910, men were dying on average in their late 40s, and the average age for a woman was 52. Well, interestingly enough, that's the average age of a woman in the United States for the past few decades with respect to her final menstrual period. So women going through menopause, you would have in 1910 not lived very many years post your last menstrual period. And so we know that our brain is aging and that we are asking it now to age. Like if the average life expectancy for a woman now is close to 80. So she's, 20, 30 years living in the postmenopausal state. Our brains are not used to that yet. And so that wear and tear on the brain is not surprising. The fact that we do see mild cognitive impairment and dementia increasing in the United States, we are living longer. And so that is to be expected. And it doesn't mean that I'm thinking that we throw up our hands and go, oh, we can't do anything about this. Yeah, we need to be doing lots of research, because if I'm going to live 30 years in the postmenopausal state, I want to live well. And so I think that's what we're all about here, is living well. So what happens at perimenopause, as we know, is that women are undergoing these sort of dramatic hormonal shifts. That's if they are undergoing a natural menopause, and a menopause at the sort of average age of around their late 40s, 50s. But we also know that some women undergo a premature menopause, and they might be I had a patient one time that wanted to get pregnant, and she, newly married, wanted to get pregnant, late 20s, went off her birth control pill, started having hot flashes, went to see her OBGYN, and she was postmenopausal at the age of 29. So, it happens. And then obviously we have people who have cancer issues or cancer risk, and they need to remove their ovaries or, undergo a chemotherapy induced menopause. And so there's a lot of ways in which women go through menopause. And I don't know if you want to start by talking about sort of the natural and what happens and then kind of go into surgical. I'm going to leave that to you.
Yeah, why don't we do that? Why don't we do that? And yeah, why don't we do that and just talk about sort of like the effects, like when it does have someone going through a menopause, so say they're in their early 50s, what
Sure.
happens? And when do things, and we know that things are not the same for everyone, right? So I think that to sort of preface that everyone experiences menopause differently.
Yes.
And so, yeah, so take it from there.
Okay. Sounds great. So, I mean, the thing about a natural menopause that's helpful is that you're giving your brain a chance to kind of get used to these hormonal shifts. Yet at the same time, some women who are particularly sensitive to hormonal changes can experience a lot of symptoms that can impact one's cognition. So, not only a direct effect on the brain, both the prefrontal cortex and that hippocampus I was talking about, but also things like sleep and mood. And I don't know about you, but my sleep and mood are very intertwined. When I wake up in the middle of the night and my brain is going, and I am really stressing out, then I'm not going to wake up in the morning feeling refreshed and like I can really tackle my day. And so, if you're having vasomotor symptoms, those night sweats or frequent awakening or early morning awakening, that can have a dramatic impact on one's cognition. I mean, there are studies of people who, with one night of sleep deprivation, showing that their cognitive performance the next day is not as good. And so we know that sleep and cognition are really, really intertwined. Yes. And physical health, if you have good physical health, a lot of women, as they go through midlife, they might have a few extra pounds that is impacting their weight and their metabolism. We know that we want weight and metabolism to also be very healthy. Blood pressure, all of those kinds of things are really important. Mood, if you're feeling depressed or anxious, that can also impact your cognition. So there's a lot of stuff that happens in that transition that can impact one's cognition. In addition, we believe, and there's data that shows that when you have changes in estrogen and then perhaps a deficit in estrogen, you can have an impact on nerve cells, both in the hippocampus as well as the prefrontal cortex. And that those nerve cells might not be connecting with each other as well as you would like. And so that can also be what we believe is one of the reasons we see this executive functioning and word finding kinds of issues, and even in a natural menopausal woman.
Mm-hmm. Well, we know that at the end, the late perimenopausal period, right, which is usually that year before the final period, or when your periods get very irregular and you maybe go a couple months without your period, what's happening is your estrogen is going like this. It's spiking. It's going up and down and up and down and up. And it's it's actually kind of going like this, right, downward, right? Does that impact, have that been studied yet? Sort of like the impact of the ups and downs? Because we know, at least I think we know, in terms of mood and anxiety, that it impacts women. And like you said before, and I think it's actually really important because the reproductive changes that happen for women are often a time of vulnerability. And some women are just more vulnerable for some reason than others, right? They're more sensitive to those hormonal shifts. Like, why do some women get postpartum depression and others don't? Why do some people go through, perimenopause kind of and breeze by and some people don't, right? But what are those ups and downs? Do they have an, and I imagine it's just really hard to tease out, right? Because it's sort of like there's all these symptoms. There's sleep, there's anxiety. People who are super anxious, their cognitive functioning is super affected, right? When all your brain is saying is what if, what if, what if, what if, what if? How can you remember other words, right? So I don't know. I'm just curious about those ups and downs. Do we know that impacts separately, just like the memory and word finding?
Well, it's interesting that you talk about the sort of fluctuation, and I do think that that late perimenopause, and again, our studies from looking at data from the Penavarian aging cohort, also some work that we've done with neuroimaging, particularly sort of in that early postmenopausal state, that this kind of up and down, if you're sensitive to hormonal flux, the up and down is really kind of problematic. And we also talk about an up and down. We're talking about an up and down predominantly of estradiol, because a lot of women are not ovulating. And so they're not also getting the up and down of the progesterone, which they were used to getting in their premenopausal life. And progesterone and its metabolite, which is a neurosteroid allopregnanolone, and people might know what allopregnanolone is because now there's a new medication called brexanolone for postpartum depression that really is, it's allopregnanolone. That's what it is. And so, people are starting to become, all right, I think, more sensitized to the fact that it's not just these changes in estradiol, but there are changes of estradiol at perimenopause that are without the usual changes that a person might experience with progesterone and allopregnanolone. Now, that might be good for some people, and for other people, they have a lot of sensitivity to allopregnanolone and progesterone, and that's not good for him. So you're right. It is hard to tease out scientifically how important the sort of up and down is, although we do think that's what's contributing to a lot of these kinds of symptoms. Because in our studies, we did a cross-sectional study during the pandemic where we asked, over 1,000 women to tell us about their cognition in relationship to where they were in their menopause transition. Were they premenopausal, squarely in that premenopausal state, perimenopausal, or post? And then we took the post and sectioned them out into surgical and people who had undergone a natural menopause. And we asked them questions on a standard executive functioning scale. And I can tell you the ladies who scored the highest, meaning they had more problems, were those perimenopausal women. But interestingly, and this is going to get us to this issue of surgery, those in the surgical postmenopausal group had the highest levels of executive functioning complaints. Those in the natural menopausal postmenopausal state were actually a little lower than the perimenopausal women. Like they weren't getting worse, they were actually getting better. And that's what a lot of women say. If I experience all of these symptoms in the perimenopause, does that mean I'm just going to continue to slide and get worse? And there's these data, as well as some other data, suggests, if you go through a natural postmenopause, the chances are your symptoms of executive functioning complaints are not going to get worse. They might even get a little better.
Oh my gosh, I have so many questions. So I'm sure our audience does as well. So let's go back then to surgical menopause. Like, so when it's sudden, when there's like a surgery, there's something that happens suddenly. And I think there's a difference, maybe, so talk about that. And then we'll get to like when something is wrong, like when to assess like what's normal and not normal, like usual, I guess, right? What's a usual, to expect, and when to worry. So let's go to those two things.
Sure. Again, it depends on what age a person undergoes a surgical menopause, because if you undergo a surgical menopause at 50, 51, you might have already been perimenopausal for a while. And so in that situation, the chances are that you're not going to have as quite a dramatic a symptom as somebody who might be 40. And somebody who's 40, I gave a talk years ago to a support group called Facing Our Risk of Cancer Empowered. So the FORCE support group for people who've had cancer or are at risk for cancer, genetic, risk for breast or ovarian. And, a person was in their early 40s and was saying, my doctors talked to me about my bone density and my metabolism and these things that could be impacted by taking out my ovaries early. But no one ever told me I might lose my mind. And again, that's a dramatic statement. And most women do not, quote unquote, lose their mind. But I have spoken to a subset of women that undergo early menopause who really do feel that their cognition is affected. And it typically is in that executive functioning domain, where I was talking recently with an attorney, no, she's a judge, and she was saying that when she sits on the bench and she is able to, she's in front of an audience, she can stay paying attention, she can focus, she can listen to the different sides of the presentations from different lawyers and what have you. But she said when she gets away from that and has to sit down and do the more mundane, writing the brief, writing her opinion, she's like, that's when she really notices that she has a great difficulty sustaining attention, pulling all the information together, and God forbid somebody distract her, because then she has to kind of like start all over again. So we get into that concept of what is salient, what is critical. And when you're on the bench and you've got all eyes on you, there's this intensity about it that keeps you attuned. But when you're behind closed doors and the task is mundane, it is very hard to motivate and get it done. And that still is part of her job. And if she can't do that part of her job, then doesn't matter how well she attends on the bench. So again, for each woman, this experience of losing their ovaries and not having that normal sort of slide into the perimenopause and post can be really dramatic and impact their productivity.
Yep. Right. Okay. So when should somebody be worried?
Well, when it's disrupting your daily life, I mean, in this situation, obviously she was still functioning at a very high level, and most women do continue to function at a very high level. I mean, they're at the top of their game. And the more we push the prefrontal cortex, the more we're going to notice that it's hard. And so that's one thing that we as human beings have to understand, is that we slog our prefrontal cortex as if we're in the gym and we were doing 3 to 4 hours of biceps exercises. I mean, our bicep would get really tired and sore if we slogged it that much. Yet we still somehow think that we're supposed to be able to expect that our brain is so focused, so involved in multitasking, all this kind of stuff all day long without any effect. Well, the brain too is like a muscle, it gets tired. And we do need moments of rest. When you can notice that it is impacting a lot more of your day-to-day function, and I would say a key feature of when to be concerned is when other people around you think there's a problem and you don't. Because they're noticing that you are forgetting a lot more appointments, you are forgetting how you did things, or you were getting lost when you were in your car and you were driving to the grocery store and you're like, how did I end up here? Those are kind of dramatic cognitive concerns that would lead somebody to saying, okay, maybe I need to see my doc. But just forgetting where you place something, missing the occasional appointment, especially if you're super busy, forgetting it's your turn to pick up the kids, or that your parent needs to go to a doctor's appointment. When you're really busy in your day-to-day life, you can only manage but so much. That is not a cognitive concern, that's a lifestyle concern. And maybe we need to sit back and say, are we expecting too much?
Right. And I think that that's also part of it, right? I think that women these days are incredibly hard on themselves, right? And so how does that play into it? Like when there's a lot of, when you're putting pressure on yourself to remember things, how does that play a role?
It plays a big role, because then when you don't, a lot of times women will beat themselves up and feel like a failure. Like I somehow I could juggle all this stuff 10 years ago and I can't now. And I'm kind of like, there was this interesting study that where people wanted to know, when do we have peak cognition as a human species? And it's a little sad what I'm going to tell you. The good news, I'll tell you the good news first, is that basically they studied chess games that have been recorded, the different moves from 1890 to 2014. So they had 24,000 chess games during that entire period of time. And they were able to study the complexity of the moves the age of the person as they were playing this game. And there's a lot about chess that is grounded in a strategy, memory, coding, things that are very complex, cognitive processes. So it's a very interesting way to kind of analyze how people have been doing and how our species has been doing for over 120 years. The good news was that our species got better. That between 1980 and around 2014 is when it really kind of took off, and people became much more sophisticated in how they performed. The bad news is that we peak around 35.
Oh boy. So acceptance, some of it is acceptance, right? Acceptance that like your memory is not going to be good as it used to be, and having strategies that we're going to talk about a little bit later, right? But I do think that this is something really, people are really worried about this. I think, prior to this, we were talking about it. People are very, very worried about their memory. And sometimes the more you worry about the memory, the harder it is for you to remember something, right? When you put that pressure on yourself.
Exactly.
Before we get to sort of symptoms and what we can do about it and some of the questions, and I'm going to start the questions a little bit early, I think, too, because I really want people to get their questions answered. It's really important to us. And so let's just talk about some other risk factors. So you said like surgical menopause. Is there something else that increases risk of, poor mood and I'm not poor word finding and memory issues?
Well, there is. And one of the things that my laboratory studies is this concept of sort of what happens across development and how that impacts brain health across the lifespan. I'm very much a lifespan person. You mentioned perinatal depression, but I've also studied premenstrual dysphoric disorder, which is more, adolescent, early adult onset. And, I've just been interested in how gonadal steroids, so what the steroids that your ovaries make, and then how they get metabolized, how all of these things can impact the brain. But the one thing that we have to remember is our early life experiences, those fundamental experiences during our childhood, also impact a part of our health and part of our brain called the hypothalamic pituitary adrenal axis, or our stress system. There's also data that shows that certain types of childhood abuse and neglect occurring at different times in a person's childhood can have an impact on actual structural changes in the brain as the brain is developing. And so we know that early life stress has an enduring impact on a number of health factors. And one of them being risk for depression, risk for other psychiatric illnesses, but also cognitive issues. And we've been studying how early life stress can impact how the brain functions in the absence of estrogen and then with estrogen being added back. And we showed in a brain imaging study upon postmenopausal women, so not peri, so these were women who already had low estrogen levels. We studied them in the low estrogen state, giving them a very complex task that really activates the prefrontal cortex that I was talking about. And then we gave them estrogen or placebo. And it was very interesting how different the women with early life adversity looked as they were performing this task. The brain region did not react the same in the low estrogen state. And when we gave estrogen back, they actually looked like people who had not had early life adversity. Wow. So it may be that there's subsets of women because of no fault of their own, their early life stress, that subset of women might have more or less responsiveness to the loss of estrogen on the brain and the add back of estrogen on the brain. And so we need to be thinking about the whole lifespan. Now, I cannot take a woman who is 48 years old and perimenopausal and go back and change what happened in the past. What I can talk to her is about ways to improve her health currently that could have also been impacted by these past experiences. So we also have data that shows that inflammation, markers of inflammation in the blood may be more relevant to cognition in somebody who's had these early life experiences as well as current life stress. So there are things that we can do to help women have lower levels of inflammation, lower levels of stress, helping them strategize, maybe you actually are trying to do too much. It's not a failure. It's just that you might be trying to do too much. And how do we constrain your current life stress so that you don't have these negative effects on your cognition and your mood and your overall physical health? So that's a risk factor that we've been looking at. And then how does that early life stress impact your health later in life? Exercise is a big thing. A sedentary lifestyle is also problematic for our cognition. Our nerve cells are happier when we're exercising.
A dose of an antidepressant, right? Like it's another dose of that SSRI or SNRI, right? So when you exercise, studies have shown mood.
Yes, exercise is incredible. It's not an old wives' tale, so to speak. There's a reason why people say, "But why don't you go out and play?"
Women don't often take the time, especially this age, if someone's going through it around like the late 40s, early 50s. I mean, there's a lot of stress. There's a lot, if they have children, they're trying to help those children launch. There's a lot of there's always something, right, having to manage. And then we're also sort of sandwiched taking care of older people, so we don't often prioritize ourselves. And what you're saying really is that it's not just one thing that we have to do, right? It's sort of like
exactly. And even that could feel daunting to some of your listeners, because they might say, oh yeah, she's going to tell me to exercise. Oh, at least she hasn't used the word mindfulness. Yeah. but
But mindfulness works. I was a skeptic, and mindfulness really does work. But I think people don't know what it means, like what it is. You know what I mean? Like it's sort of like, because when you do it, and it's actually, I think one of those things, like when you were talking about the judge, she's actually being mindful when she's on the stage, on the thing, right? Because she only has to do that thing, right? She's not thinking about all these other things. So she's actually being mindful. So I think if people realize that, like I actually realized, I'm a therapist, I actually realized that when I was in session and I was just focused on that one person, I came out feeling great. Even though like some of the sessions would be really hard and intense. And I finally asked somebody, and someone said to me, like, Donna, you're being mindful, and that's why you feel good. So people actually do it and they don't know what it is. And then it's a skill that has to be learned for other parts of your life.
Yes.
So I'm going to just ask, we have a couple more questions. I want to get to the questions. So hormone therapy, does it help? I know, more people are open to it now, which is great because hormone therapy really took a nosedive in the early 2000s. And now people are getting more information, and we're providing information to really do a risk benefit analysis. But tell us about hormone therapy and cognition.
Well, if you go through menopause early and you have no reason to not need, not to avoid hormones, so like you're not at risk or what have you, or if you are at risk but you've done the surgeries and so the tissues of concern are no longer in your body, the data suggests that taking estradiol can be helpful and kind of keeping some of these cognitive issues at bay. It's not perfect. It's not a panacea, but it can definitely be helpful. If you have reason to not take hormones, we've done a couple of studies with the medication lisdexamfetamine, which is a type of stimulant that is FDA approved for ADHD. And again, why ADHD? Well, we were studying women who had new onset executive functioning difficulties. Executive functioning difficulties, ADHD onset in childhood is kind of the prototypical disorder of executive functioning. We've all seen it. We know people who have this problem. Many of us may have the problem ourselves. And so the thing that we said is that, as a clinician, I kept hearing these stories from women, and I was like, gosh, it sounds like they're getting ADHD symptoms. So we decided, okay, let's study this. And we did show in both studies, one's been published and one's under review, that basically the treatment with lisdexamfetamine is better than placebo with respect to helping women with these executive functioning complaints. We also have data, though, that even subclinical levels of depression and anxiety can have a negative effect on these executive functioning symptoms. So we want to make sure that if a woman is experiencing some depression, anxiety, even if it's not at what we consider a major depressive episode level, we want to address those as well, because that can also contribute to these symptoms. So there are different forms of treatment and interventions based upon somebody's presentation. I will tell you across the board, if a woman's not sleeping well, I'm going to do what I can to tackle that piece.
Mm-hmm. Yeah, right. So do you think that people can have ADHD symptoms starting at this time without having ADHD prior?
Yes, but it's not, we wouldn't want to call it ADHD symptoms. Really, I want to kind of stay away from that terminology too much. It's executive functioning difficult, because ADHD as a diagnosis has its onset in childhood. Now, people might not recognize it until they get older, and women are notorious for not recognizing, and clinicians treating women, girls, and what have you, miss it, because a lot of times for women it's the inattentive sort of difficulty focusing and staying and paying attention, working memory kinds of issues. They don't have some of these sort of external behavioral issues that you might see in young boys. But in our studies, one of the things that we really focused on was excluding women if I thought that they had a diagnosis before or they just had a misdiagnosis, because we really wanted to know, is this medication helpful for women for whom these symptoms really didn't become a problem? Now, maybe they had genetic risks. A lot of them did say to me, oh, I have a son with ADHD, so I know what you're talking about. But they themselves had never met criteria for it or had those symptoms until they went through the menopause.
Okay, great. Okay, I'm going to ask questions, and hopefully some of the other questions I have will just sort of flow in with that. So somebody asked, what about pre-existing conditions such as a mild TBI, so traumatic brain injury with small but noticeable long-term effects? Would the cognitive implications of menopause be more profound?
That's a very good question. I think the question, I don't think we know whether it's something that's just additive. So, like, for example, you already have this kind of injury to a part of the brain, and then you add upon that the changes in the hormones that are perhaps even impacting the area of the brain that was injured, or just these other areas that I'm talking about. So you just kind of notice, okay, there's another decrement. So I can't say it's additive. I don't know that that would be the case automatically, but you would be undergoing the same kind of hormonal fluctuations that somebody without a TBI would be undergoing, and therefore potentially at risk for some of these other changes.
Okay, great. Somebody else asked, what are some of the ways to increase my cognitive functioning as it is affecting my job? It's becoming more noticeable as my work requires innovative thinking. And I will just say to our listener who asked that question, you are not alone. We hear this all the time. I'm at that age. My friends, I mean, this is, I think, a huge thing it's a great question.
Well, then I think some of the questions I would have is, obviously you want to keep is this a job you want to keep? I mean, it may be that the job is shifted, but if it's a job that you really want to keep and it's just the nature of the job is changing, it may not be your skill set. And so the question I would have in that circumstance, I mean, my job is so multifaceted, and there are pieces that are really not in my wheelhouse. Probably they've never been in my wheelhouse, but I have so much going on now, and my job is so much more demanding. And there's a lot of balls in the air, which exhausts the prefrontal cortex. I mean, it's exhausting to the brain. So I know that I have to recharge more so than I used to. Not just because of my age and not because of my postmenopausal status, but also because of just the nature of how complex the world around me has gotten. I mean, barraged with emails, barraged with, technology. I'm a senior scientific advisor to our Brain Innovation Center, where we talk to tech partners all the time, and just trying to wrap your head around all of this new information. That's the other thing that we don't do as well as we get older, is that, it takes us a little bit longer to learn new information, our processing speed slows down. And that's the same thing if you're a male or a female. So I feel like I have to take breaks during my day, give my prefrontal cortex a bit of a rest. I do sit for a few minutes. I'm a firm believer in breathing and trying to get breathing patterns that help myself to relax. And so that helps. That's a strategy that I use. I also try to figure out what can I bequeath to other people who are better at those things than I am, because I don't have
Ask for support.
yeah, I don't have to do it all. I can't do it all. And then what I try to do is figure out if I'm not as good at this, but it's still in my wheelhouse to do, I try to do it at a time where I'm not tired. I try to do it at a time of the day where I think that my capacity to manage it is better. So again, it's a lot of lifestyle, professional lifestyle strategies in order to be able to manage these things, because it is what it is. I hate to say it. We're getting older and, we can't always train our brain to do better at things. I think we have to be honest with ourselves and say, what can I do best? And if my boss is expecting me to be best here, can I show my added value here? And can I tackle these things when I'm freshest?
Right. And I think that leads us a little bit to cognitive behavioral therapy, which is in my wheelhouse. So I see people who are perimenopausal, menopausal, and they are just struggling. And, I help them with skills. And I've used those skills myself as somebody who went through surgical menopause and still have a lot of cognitive issues. And one of the things I tell people is you have to, really say like, oh, I'm having trouble finding a word right now. And that's okay. Instead of sort of beating yourself in that moment and providing that stress. So a CBT type therapist may help. And tell me about what your thoughts are about CBT, cognitive behavioral therapy, and mood and
one. I love cognitive behavioral therapy. I'm a psychiatrist. It's an evidence-based therapy, so and it works for a lot of different things. I also am pretty much a fan of psychodynamic psychotherapy too, and I think that again we use these things differently. But I think for short-term types of therapy, CBT is great, particularly if you're finding yourself, doing a lot of self-flagellation and sort of beating yourself up. Where the more psychodynamic kind of therapy comes in is if you're kind of wanting to understand why you're so hard on yourself and sort of some of the interpersonal and individual relationships that have led you to be that way. So I typically tell people start with CBT first. If you're not sleeping well, CBTI, so CBT for insomnia, is also really important. But this kind of self-flagellatory stuff we do and the anxiety that we cause for ourselves just makes this so much more difficult. And I just want to say to people, if you're waking up in the middle of the night, nothing that you are thinking about in the middle of the night is rational. Just middle of night thinking is crazy thinking for all of us. We catastrophize. We think that the world is falling down around our ears. And, there's stressors out there, but we're not prepared in the middle of the night to solve problems. So I try to tell people, let it go. Just try to let it go at night.
And I would also say, because I used to hate the word self-compassion. I used to think it was sort of like hokey and blah, 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 but one of the things you can say instead of like saying like, oh, changing sort of how you think about your word finding, right? And say you're beating yourself up over it. It's not saying like, oh, that's great. It's just saying like, oh, I'm having a really hard time finding that word. That is actually self-compassion, or I'm having a hard time focusing, right? It's just sort of saying, oh, I'm having a hard time right now. It's not like trying to say the opposite. It's just, so that's self-compassion. So I just want to kind of like, for our listeners, like, it's really just important to acknowledge when you're having difficulty and just say, it's okay, right? It's okay. Okay, I'm having trouble finding that word. And you'll be surprised a few minutes later or an hour later, you're going to remember that word because your anxiety level about it is much less. Okay, I'm going to get to more questions. I could talk about that forever. Okay, I have fibromyalgia and experiencing a lot of duplicative symptoms such as brain fog, perimenopausal symptoms. It's hard to know what comes what. How do you work with two different providers, PCP, GYN, to assess, treat? And that's a very good question. That could be like a forever question.
Oh, it could be. And this is where I'm wondering, I mean, a lot of PCPs really they do understand hormonal issues as well. I don't know that one has to go to a GYN to really sort of grapple with that. And I mean, actually, this is the kind of patient that typically comes to me because they get referred by their PCP or GYN. They're having difficulties with cognition. They might have some mood symptoms overlapping. Often they're not in the midst of a major depressive episode, but they're anxious and kind of experiencing a sense of ennui. And, what's helpful, I think, if you can find either a PCP or even a psychiatrist who's a menopause expert, or even a nurse practitioner, if they really know what they're doing when it comes to working with midlife women, then it might be a way to kind of pull together sort of a more comprehensive whole person kind of evaluation and discussion. Because, if you have fibromyalgia, obviously there is some immune component to, and sort of inflammatory issues are pretty common in that illness. And, so what's the fibromyalgia, the achiness and fatigue that you might be experiencing versus what's perimenopausal? Again, I would think a PCP could manage that, or somebody who quote unquote considers themselves more of a menopause expert. Just because somebody's an OBGYN doesn't mean that they really like or feel some proficiency working with the perimenopausal woman.
Right. And we have a whole, we did one of our past menopause talks on that in January. So if people want to go to that, and we also have on our website, we have tips to finding a menopause provider, and in our upcoming newsletter, we're going to be doing something on that. So that's a whole big sort of question about that. So we won't get into that. Right. So our next question, does long-term use of SSRIs, so things like Prozac, Zoloft, increase the impact of perimenopause on cognition?
No, there's no evidence of that. I just was speaking to one of my menopausal aged women, female patients yesterday, and she is having such a terrific antidepressant response to sertraline, and which is an SSRI. And we were just talking about, she's like, I think I just am going to stay on this because she tried to wean off and was fine for a while, and then it came back. And I'm like, this is the best I've seen her because she's a new patient to me. And I'm kind of like, yeah, there's no reason to go off this. No, I mean, really, I just stay on it.
To your point, just sort of, we weren't used to living this long. And so I know people are really afraid of, like, some people are afraid of medicine, but at the same time, like, I was having this conversation last night with my family, like, why suffer? Like, this is the thing, like, we're so used to just suffering and being like, oh, I have to live with this, but really it's about quality of life. And if there's something out there that can help, right, why not try? At least try. That's sort of the thing, right? So okay, someone asked, what if on hormone therapy, but still struggle with anxiety and waking up around 3 a.m. and executive functioning, small changes, but grandmother and mother with dementia, and they did not have hormone therapy during menopause.
Mm-hmm. So if you're on hormone therapy, I think the real question is, what hormone therapy are you on? And, a lot of gynecologists, because and primary care doctors and general internal medicine folks, ever since the Women's Health Initiative, there's such a push to really have people at lowest possible dose. But my feeling is that if you're going to take a medicine, and we can say that hormones are a medicine, even natural hormones, you're taking something that has a physiologic effect on your body. So let's just call it a medicine, okay? Whether it's natural or whatever. The bottom line is that if you're taking it, there are some risks associated with taking hormones, like increased risk of blood clots and things like that. You might as well take the amount that is going to work for you. So if you're on a super low dose and still having symptoms, this is where I would go back to your doctor and say, hey, if there's no real medical reason why I couldn't be on a slightly higher dose, could we try a higher dose? The other alternative, so that's one alternative. If you have had, some reason that this is the dose you're on and this is as high as you're going to go, then adding an SSRI can be incredibly helpful for sleep, and in addition to mood. So it could be that you do a little bit of a combination between, the hormone and the SSRI, or even the SNRI, sort of the venlafaxines of the world that affect both serotonin and norepinephrine. And then some women really like bupropion, which has more dopaminergic effects. And so, again, it really depends. I can't give a one size fits all, but I want to be reflective of the fact that this desire to have women on such low doses of hormones, you might not even be on something effective for you. So then you have to decide, do I stay on this or do I go to a dose that's more effective? There's no reason, though, that a person would need super high doses. And I definitely have a colleague here at CU, at the University of Colorado, Nanette Santoro, who is a very well-known menopause expert, reproductive endocrinologist. And she has had people refer to her on super physiologic doses of estradiol. And there's just no real reason that you would need to be on a dose like that.
Mm-hmm. So one person just asked, and this is just really interesting and important because I think that the medical community has not caught up with the top menopause researchers on hormone therapy. And then we're going to get to people who can't take hormone therapy. But this person said at the age of 63, her gynecologist just decided based on usual practice to cut her hormone therapy prescription in half. And you just answered that question.
Yes, because the North American Menopause Society, and that might be, if we don't have the link, the North American Menopause Society does have materials that it puts out every year about various different, kind of guidelines and recommendations. And, the most recent recommendation from NAMS regarding hormone therapy is like 60 and below, unless there's some compelling reason. And then, they're not saying as an absolute contraindication, but, they are suggesting, okay, we need to really reevaluate because there's not as strong evidence of benefit among women in that 60 plus age group. And but at the same time, I know Nanette even will let women in their 60s use hormone therapy if it's something really positive for them. I think the main thing is to talk to your doctor and say, this is not working for me, and see if they'd be willing to go back to the other dose. But they might write in your chart, I spoke to the patient about the risk and benefits, and the patient recognized that this is, that they're above 60. And, so they're going to cover themselves because they are concerned not only about themselves and their malpractice, but, people don't go into medicine and become a doctor to do bad medicine. They're going, and part of what we do is we read guidelines. Because the patient in front of you may not fit the guidelines, and that's the art of medicine, is how do you think about the patient in front of you, but you also have to think about the guidelines, and so that might be what they're following. Mm-hmm.
Got it. And then what about people who can't take hormone therapy, people who have hormone positive breast cancer? There's somebody who said she was diagnosed with Lynch syndrome while being treated for breast cancer. So she had a hysterectomy. What can I do to increase cognitive decline without hormones? My doc prescribed Paxil, but it seems to worsen my symptoms.
Well, then she needs to try something else. Again, Paxil is, paroxetine and other SSRIs and SNRIs are the kinds of things that people are going to try for various kinds of symptoms. If somebody is coming in with mood symptoms or sleep problems, they'll probably go to the SSRI. Also, if you're having lots of hot flashes and night sweats, they'll probably go to the SSRI or venlafaxine and SNRI.
SNRIs. I mean, we had a Dr. Soros from Canada, and he was really his data showed that the SNRIs really help, including.
No, and that's also definitely a pathway to go. And again, people respond more or less to these medications. And so I would say try something different. But if it's primary cognition that the person is having difficulty with, and I'm saying again, in these executive functioning domains, so organization, activation for work, staying focused, processing speed, working memory, if it's those kinds of symptoms, then there is a growing literature that we've been contributing to we're trying a stimulant medication. So an ADHD type medication or medication that's FDA approved for ADHD. And again, lisdexamfetamine is the one that we've studied. Some people might.
That one is Vyvanse. Is that the one? Mm-hmm.
Yes. And then with full disclosure, the most recent study was not supported by the company at all. Some of my earlier research with this medication, we did get some funding from the company who makes the medication for that earlier study. The most recent one was funded by the National Cancer Institute. So it did not receive, and that hopefully is going to be published in the not so distant future. But in any case, there are other options. Some people think bupropion or Wellbutrin can have some positive effects on cognition, certainly anxiety, depression. Definitely, it's FDA approved for the treatment of depression. It's not the medication I would go to for vasomotor symptoms. That would be either the SNRI or SSRI. Probably, to your point, the SNRI first. If it's vasomotor symptoms.
Right. So we didn't get to all the questions, and we really apologize. But you know what we're going to do? Actually, we'll take some of those questions, and we're starting to do questions and answers in our newsletter. We'll look through them. We'll really try to address them. Maybe we'll do that. So I apologize to people profusely for not getting to all of them. This was so informative. It really was. And I think that, again, we can do a part 2 in the fall because there's so much to learn and that we can get to. So we really want to thank everyone for coming. We want to thank Dr. Epperson for being our panelist today. Dr. Epperson, you can feel free to, if you want to leave right now or you want to stay on, we're going to just do a couple housekeeping items right now. But thank you so much for joining us.
Well, thank you. It's really a pleasure to be here. And just to everybody in the audience, you are not alone in your concerns about, menopause, aging. Again, it's relatively new experience for our species. So
be kind to yourself about it. Be kind, be nicer, right? Be nicer to yourself about it, and know that it's partly normal. Like a lot of it isn't just normal, right? And I get that word. I know that word is, what is normal, but like it happens.
And there are things that you can do to really help your quality of life. All right.